Bismillahirrahmanirrahim. It's indeed a great honor for me to give a little talk about single center DBS experience in Pakistan in the first National Parkinson's Disease and Movement Disorder Conference. As we are all aware, as we all know that the STN as a target, Professor DeLong has a great contribution for that. And Professor Benabid from France, he was the first one to do deep brain surgery for Parkinson's disease. And we have more than 1,15,000 patients worldwide who have received DBS. It could be actually more than that now. Now, just to give you the Darling DBS for Parkinson's at Lahore General Hospital where I work, the two busy centers in Lahore are, one is the Lahore General Hospital and the other is the King Edward Medical College Department of Neurology. And we on average get about 25 cases in a week, each center, of pure Parkinson's disease. Mind it, they are not primary referrals, they are tertiary referrals. Most of them are self-referrals, but some patients are referred as well, and they have been on all sort of medication before. 30 to 40% they do have motor fluctuations, on-off phenomena, and drug-induced dyskinesia. And how they are treated, when most of them, they stick on those medicines and they don't seek any further treatment. Those patients who have unilateral disease, they are subjected and are poor. They are subjected to lesional surgery, which we are offering free of cost at Lahore General Hospital. And those cases who were affording had a bilateral disease, they were obviously being referred abroad for DBS surgery. That was the norm before. Now, how modern stereotactic surgery started at Lahore General Hospital, I would like to tell that Lahore General Hospital started functional neurosurgery, ventrolateral thalamotomy since 1964. Professor Bashir started that. And that continued till 2010 when his student, Professor Nazir, retired. They mostly did ventrolateral thalamotomy, unilateral, and it was all X-ray based. Maybe they might have done few cases on CT scan, but they were basically X-ray based and ventriculogram based. Now, when I joined this unit, and I have to say that Professor Jooma is the pioneer of this surgery in Karachi and that part, and they were doing CT based surgery, and he also did few pallidotomies as well, apart from thalamotomy. Now, in a quest to improve this functional surgery, MRI compatible Lexel G frame was purchased in 2005, but initially it was only used for biopsy. And I would like to say that we have all generations of Lexel frame as from 1964 till date at Lahore General Hospital. And you can have an idea of interest of this center in functional neurosurgery. We purchased 1.5 Tesla MRI in 2005, and we are installing 3 Tesla MRI next year at the Punjab Institute of Neurosciences. We purchased Shelton brand Digital Atlas in 2011, and this Atlas cost 1 crore. Previously, the lesion was being done by the old version of the Cosman generator and sometimes with the diathermy only. And we purchased this Cosman G4 RF generator in 2011. We purchased fluoroscope in 2011. Now, you can tell this is the new lesion generator, and this is the old one we have at the Lahore General Hospital. This is the old way of defining ACPC line and ventriculogram, and this is how we do it now on surgery plan. This is the old frame. This is the new MRI compatible Lexel G frame. which is the latest and which is used across the globe. Now, jumping to the first deep brain stimulation, first case of movement disorder on modern lines. When I say modern, it means MRI based. Number one. Number two, it is digital atlas based. Number three, it is stimulation based to confirm the target. I'm talking about lesional surgery. And number four, you have all variations of temperature due to the latest Cosman lesion generator. So that you first stimulate, then make lesion at 60, which is reversible. And if the patient tolerates that, you increase it to 90 for 1 minute. So that I call modern lesional surgery. So initial target was VIM when I started this in April 2012. Then I thought that I should move on to GPI target, because that's not enough. So in August 2012, I did GPI lesioning, first unilateral in a Parkinson disease, then staged in Parkinson disease with a 6 week difference, and then one stage in dystonic patients. We have got a lot of experience and a lot of patients, and we're going to publish it and presenting in different forums. In August 2014, in a quest to start the STN DBS, I read some papers and thought, why not to do lesion at STN? We did few cases, and I have also done 2 cases of chorea, but one of the patient had a good response. And also I used STN, but I thought the side effect was 2 of these, about 5 patients, they developed chorea post-operatively. So I have abandoned it. No patient developed hemiplegia, but the chorea was very, I got very depressed with the intractable chorea after STN lesioning. And in October 2014, we did the first case of bilateral DBS stimulation for Parkinson disease. Now, till date, we have done 96 cases over last 3 years, actually more than 3 years, because I became professor in 2012, so I started this at that time. VIM thalamotomy, it was all unilateral. On modern lines, it was done in 40 cases. GPI paradotomy was in 35 cases, 20 are the dystonic patients. We've got a large referral of dystonic patients, and I have to admit that dystonia respond very well to lesion surgery, and I can prove it. 15 cases were of Parkinsonian rigidity. We have done staged bilateral paradotomy and as a one stage. One stage is usually done in generalized dystonia. And I have discussed many authorities, a couple of people are doing in Turkey as well. And somehow the patient tolerates single stage paradotomy very well. I was very scared to do it to begin with, but when I read and when I personally communicated to a couple of people, I got convinced that this is without side effects, and it is indeed. Unilateral STN lesioning was done in 5 cases, and due to the reasons I have explained, I have abandoned it. And based on this stereotaxy experience on the same equipment, I always had a quest to start DBS in this country. And till date, we have done 16 cases of bilateral DBS. And our technique is do everything at the one go. It's a 6-hour surgery in which we actually plan, we imaging, bilateral electrodes placement, and IPG under GA in the same way. Because we don't subject, I understand that in stages, the 2 or 3 stages, but we do as a 1 stage, as in most centers of Europe. Now, 1 year of DBS surgery, 15 patients of Parkinson disease. There are a couple of patients of dystonia have been lined up, but they are all on sort of through the Chief Minister's help. So their money is being approved. So when it will be approved, we'll be doing it. 1 patient of dopamine responsive dystonia. That's a rare scenario, but we have done it with very successful results. That was the clinical diagnosis. Patient, they come to me. But one thing is that I would not subject a patient to DBS surgery unless he has been seen by 2 neurologists at least of our center. One is Dr. Shahid, who is based, he's assistant professor, he's based in the Lahore Hospital, and Professor Atar Javed is a professor of neurology at King Edward Medical University. And we always ask them to have a double check and sort of see things, how they work. And I don't do anything without involving my neurologist in the initial assessment. And during the procedure, my neurologist is there in assessing. And during the programming, I do programming myself, not the neurologist is with me, but we're in the middle of training our neurologists for programming. Now, diagnosis should be very, very clear. There should not be a case of atypical Parkinson's disease. Second is the cognition should be good. And if you have any doubt, we have on board a group of a psychiatrist and a psychologist. Now, it's their domain if they think that this patient has some cognitive problem, and obviously everybody goes through imaging and everything, then they can have a detailed assessment. And if needs, I actually sort of, with this blessing of WhatsApp, across the globe, I can sort of use my contacts and discuss with them. And a lot of these cases, honestly, especially, I mean, my mentor is Dr. Shurman from Amsterdam. And even for lesional surgery, if I show you my emails, they're all full with every single case being discussed with him and getting feedback with him, where to do, which one to select, where to make the lesion, if you have a problem, what to do. So it's not the DBS we started all of a sudden. There is a long history and tradition behind that of our unit and personal input for last couple of years. We should have a clear evidence of motor improvement with Cyanamide, with good motor function in best on medication state. This is very important. In general, surgery makes off state more like an on, but really does better than the best on state. So if the patient in the best on state is wheelchair bound, there's no point in doing DBS. And if the patient in best on state, whatever he is, he can't go beyond that, so far as the motor functions are concerned, even if you do DBS. So one should have very realistic, expectations. Those people who are non-affording and they somehow afford 2 million rupees, they think that they would be new man and they would be young man and they would be running a marathon and all sort of things. So you have to do counseling. Otherwise, even a good DBS would be a source of disappointment for the operating surgeon who has spent 6 hours in the OR. Age, we are very particular. The eldest I have done, you have seen Tayyab Siddiqui, he was 73. I have done 169. My youngest patient is 22. The others are barely 60. 55, 60. And as you all know that in this part of the world, in this region, somehow we have early or young onset of Parkinson's disease. In the West, the all series are very 65, 70. I mean, a lot of centers, they don't offer this surgery after 70. Obviously, in all patients, they have screening MRI, which is very widely available. Now, exclusion criteria, if they don't respond to medication, they don't respond to. And I tell my patients that DBS can only work with medicines. It's a complement to medicine. This treatment is a complement. It's not a solo treatment. It's a complement to medicine. If you think you would be off medication, no, you can't have DBS. DBS actually basically fills the gaps in between the medicines. That's how I explain to the patients. Severe disability in the best onset, I have explained to you. Dementia, absolute contraindication. Because, why? Why dementia is a contraindication? A, they can't appreciate what the good DBS has given to them, number one. Number two, they can't cooperate with you during operation. It's life-saving. And three, the studies have shown that there can be slight intellectual decline after DBS. So if somebody is already demented, there is no point in doing it. Unrealistic expectations, I've already told. End-stage disease, very, very important. Many times patients are sent to me, they are wheelchair-bound, and they have money in their pocket, and they said, Dr. Saab, abhi operation kar de. And I said, unfortunately, you are not a case for surgery. So end-stage disease and early, they are not suitable cases for Parkinson's disease. Your aim is to touch the middle tier. Those who have spent 5, 6, 7 years on the treatment, and they are just getting sort of dyskinesia and other things, but not waiting too long that they are unstaged and they have axial symptoms and advanced disease, because DBS can't reverse that. So that's the contraindication. That's very, very important. Among our patients, we had 11 male and 5 female. Age, I've already told you, 73 was the highest age. We had 73, then 70. Then this is the sort of most of the cases. We had 122. That was the first case. Predominant features were, of course, rigidity. Also, actually, there are few patients who only have rigidity. You don't get pure tremors. You always have some rigidity, as you know, and other things going on. So it is just on the basis of predominant symptoms. And this is the gait problem they do have. Then this is the speech problem. And then the commonest, I think, what I have seen is a non-motor is they have some psychiatric symptoms, problem with the sleep. Constipation is the commonest. They're all constipated. They have a constipation, and then they have some psychiatric problems. And my experience is that the people tend to hide to the neurosurgeon when they come. They don't tell their psychiatric history, although they have been on all sort of medications for sleep. They think as a sleeping pill. So, and I have also seen that the psychiatric problem, temporary, transient psychiatric problem, were in 1/3 of my patients after DBS, which settled just after 2-3 days. And then, but if somebody is a known psychiatric patient, obviously you should thoroughly assess these patients, get it assessed by a psychiatrist. Average time to surgery was 11 years. We were not doing surgery for 3, 4, 5, 6, 7 years. Even now, there is a case I have just discussed with one of the neurologists, case referred from Kuwait. They've got the money in their pocket, they want it done, but obviously it's only 5 years down the line. So we have decided not to go ahead with the surgery at the moment, because the patient can be all right with medication for another 2-3 years. Follow-up, we've just started, is about just a year. So 3 months to a year. Last DBS was done only 2 days ago, and the other one is expected in about 2 weeks' time. Now, we just, it wasn't easy to start DBS in this country. Why? A, you can't do this procedure if you have interest and you have not been trained in that. When I was being trained, DBS was not available in America. I'm British trained, so the first workshop on DBS I did in Sitges in 1996, I remember. And at that time, all the American neurosurgeons who had interest, they flew over to Sitges. So it started in Europe, so it came to Europe first. So my interest in functional surgery, I assisted only one to my professor at that time, and then I moved back to Pakistan in '99. So, and then when I worked in a center and moved to Lahore General Hospital in 2005, where everything was there, I had forgotten everything. So just to revamp things, I got to get retrained in that. And I started with Amsterdam, with Dr. Schurman. Visited twice, thrice, was going to him just to watch an operation, assist him. He was very kind to let me assist and come back. And then I spent 1 month in Ohio State University with Professor Razai team. I was just observing. I was there for endoscopic fellowship, but next door DBS was being done, so got good relations with them, and sort of was watching how things get done, although I was preparing for last couple of months. Problem with STN visualization. I got 6 protocol, 1 from Ohio State, 1 from Amsterdam, 1 from the net. But there was nobody who could actually transfer this protocol to the MRI machine so that I can view it. And I got really confused. I was unable to basically see STN as well as eyes, as other people visualize it. So I had to get application specialist from Singapore. So he came and he sorted out this thing within 10 minutes. So you need a person who really knows his job if you want to get it done. And just sort of when you start doing a setup, if you don't see the STN, because it's a visual surgery, you actually see the target yourself. If you don't see it well, you are not going to choose it well. Availability of trained technical staff from Medtronic. As you know, those people who work in Europe and America, the Medtronic gives the support. No trained surgeon can do without support. Support means they sort of do the test stimulation with MERs. You have a neurophysiologist. We didn't have any neurophysiologist and for MERs and other things. So I worked as a neurologist. I worked as a neurophysiologist. I worked as a neurosurgeon. I worked as a one who was doing the programming as well. But now we are training our people and expanding. So when we spoke to Medtronic, the Indian guys, for this region state, they refused to come. Janardan, he said he's happy providing this sport in South Africa rather than Pakistan. Okay. Then Medtronic was very kind to send somebody, and we lined up, and that patient was sent back from Dubai because he was not covered by Medtronic to come to this country, because something happens, then Medtronic would have to pay a lot of money. Then I made a lot of hue and cry and used my international links, and people pressurized the Medtronic that why don't you start this procedure in Pakistan if a surgeon is interested, if there is a madman there, why don't you provide him the services? And I said, if I have deposited the money and the implant is with me, you are bound to provide me the services, backup services. I'm not going to back out. Then after a lot of effort, that proctor was sent to me. And that proctor initially helped us with about 8 cases. So what was he doing? He was not scrubbing up. He was basically providing us the MER support. The lead point was being flown from Beirut, and he was providing the MERs and this target and this and that. And I thought, every time we have to get him, we have to get a security clearance. The Medtronic company spends about $10,000 for single proctor visit, because he has to provide the security clearance and security cover in Pakistan, and a 5-star stay. And I'm very glad that Medtronic supported me a lot, and they spent a lot of money. Whole credit goes to Medtronic. And then I thought that I should develop my own team. I trained my own senior registrar, who's very good in computers, sort of helping with the MER machine. And nowadays, last 5 cases we did on robotic arm. Just on Skype, we were with him, and my senior registrar, he does everything. When there are spikes and popcorn noises and things, it's everywhere. It's clear that these are the targets, and you basically confirm with stimulation. If the symptoms go away, you're at the right target. So I thought that's not a big deal, although it's not ideal, but we have to tailor it according to our own requirements and our own circumstances where we don't have specialized services. So the last couple of cases we are doing, we have done even without his remote assistance and support. So we are independent now, so far as the MER, and we have ordered our machine. It's on its way from Germany. Inomed machine for 70 lakh we have purchased, our own Inomed machine. Security concerns I've already discussed. Now, financial constraint, the only thing is, it took me 6 months to negotiate special price for this region. This price is not available in Europe and America, the price which we are getting. Now, it's a single sitting procedure. All medications are stopped, the frame, the usual things. We do MERs and IPG under GA. I think I've been very lucky that we did not get even a single infection. And this is a public hospital in which we do. But I think the whole credit goes to the disposables, because we use everything disposable. the multi-leads, the electrodes, we don't save money. We don't put them in solutions and things. We open new things. And in a procedure, about the gloves are changed about 3-4 times when one whole team changes. So I think I'm just lucky. I would not say more than that. We use fibrin glue so that there should not be any brain shift, and we always have anesthesis there because most of these people, but his main job is basically to keep the blood pressure low. It's just if it's more than 140, there are more chances of hematoma. Now this is brain imaging, computerized guidance and millimeter precision. This is the STN. This is the red nucleus, this is the STN. And this is visible on a special protocol. You would not see this nucleus on an ordinary MRI scan. So you have to have a special protocol for that. Yeah. This is the path we detect on the surgery plan. Now, this is not a net picture. This is the pictures from my own theater. This is not a net picture. This is the setup. This is the C-arm monitor. This is the MIME operating. This is the microelectrodes we have put in the patient set. And this is the spikes which we are getting from the monitor. This is the, and I think we are lucky that all of our MERs were positive. I have seen even in advanced center that sometimes it's a real problem if you deviate to get the positive MER spikes. I think we were just lucky that we got MERs in we have not implanted even a single electrode without positive MER and without confirming on-table relief of symptoms with stimulation. We have not done any blind therapy at all. We don't do test stimulation with the lead. This is the intraoperative mapping we tend to do. Now, regarding the final target, we start at -5. If 0 is the target, we start above that and gradually come down with 1 millimeter, the MER, and 2 mm with microstimulation. And usually our targets fall 0, -2, or +2. Most of them are in that range. They're not beyond that. This is the same with the left side. Now this is the young patient who has a bowed posture and short stepping gait, suffering from Parkinson disease. It's got a rigidity. And this is how we do. This is the Lexel G frame and the local we put it. It just takes 10 minutes to put that frame. This is the 1.5 Tesla MRI. And I'm sitting in my theater. These images come there by the wire. And this is we transfer these, and this is the incident we make. All type of tips you get from surgeons, how to do this. We always use stim logs. In initial case, we use the other ordinary one with one case, but we had a problem. So I've decided to pay more and get the stim log, which is the standard across the globe. MERs, we use all these. This is a spikes. I think it's not a big deal, honestly. When you start doing it as a challenge, you start getting the spikes. Preoperative confirmation with the C-arm. This is the Medtronic drive. We've got our own drive. That's the Lexel drive. I don't like Medtronic drive. I think Medtronic guys are sitting here, but I think this is the, now we're doing the part on the GA, the abdominal part. It's a 40 minutes procedure, putting it under GA. So patient basically gets GA for 40 minutes only. The rest of the procedure is under local. So this is immediately post-operatively, immediately. This is the Khalid Hussain, our second case, 69-year-old. He was an engineer suffering from Parkinson disease, tremors, rigidity, both posture, bradykinesia for good 12 years. And this is the post-operative done by his own wife. He's playing with his, he's moving his left arm a little bit less, but he was very frail. But he is happy. He's a doctor family. He's having an independent life. And his family says, his sons are in Canada. He said, when my dad talks on telephone, he's got a bit of emotion in his voice. He looks like a dad. He sounds like a dad, which he wasn't. This is Shakil, the youngest patient, 22-year-old. This is a strange case. I did actually thalamotomy first. He had a bilateral tremors. I did left beam thalamotomy, his right side tremors are out. And I said, your treatment is DBS. And he met his MP, and that was the first case of DBS. So the Chief Minister Shahbaz Sharif donated 20 lakh rupees. And I did his bilateral DBS. This is the post-operative. This is a prime example of a case who had a one-sided Wim thalamotomy, and the other side he had the functioning deep brain stimulation. This is a patient, again a chemical engineer by profession, and he had bad psychiatric symptoms for 2 days. That really pissed me off, but he was controlled and despaired of. He can't, as you can see, he can take only little steps, short shuffling gaits, be sported. Our every case is documented. Every single case is documented in terms of our MER recordings, our target, pre-op video, post-op videos. They're all documented. And this is the dyskinesia he was getting. It's just getting the idea. And our initial cases were all medical families, their daughters and sons, they're all doctors or somebody living abroad, doctor who suggested to be operated here. And this is the post-operative. He's really very well and a source of great referral. He's fine. He's very well. He doesn't have any problem. This is again patient from Sialkot. She had a bilateral tremors, rigidity, and the usual story. The husband lives in Dubai. And this is the preoperative movie, and you can imagine how bad she is. And this is the post-operative. They come every now and again just to say hello. Or this is again a patient from Narwhal. Businessman, mainly he had a rigidity, very little tremors, bradykinesia, rigidity. That's the walking. Okay. Again, good. I think DBS works very well for tremors. It is also very good for rigidity. Problem comes with when you have problem with the speech, when you have a problem with the gait, then you have a problem and less perfect results. But for bradykinesia. But it's excellent for tremors and rigidity. No match. This is again a patient from Islamabad, a banker, bad tremors, and rigidity and bradykinesia. And dyskinesias. He could not. He's got a young daughter, and the whole family, mashallah, was very sportive. It's in my room. If you look critically while his arm swing is less and the type is, but you can't make a new man, You only can give 60-70% improvement and 30% improvement in the UPDRS. You can't make a new person. If you expect totally new, it means you don't know the disease and you don't know the outcome of the treatment. This is another patient. You know, patients, many of patients are young, bilateral tremors, problem with the gait. Dyskinesias. This is post-operative. Both arm swings, good speed, without dyskinesia. And DBS works very well for dyskinesias. If some patient has a drug-induced dyskinesia, in any of my patients, none of my patients after surgery had dyskinesia. Okay, they might have imperfect results with a gait or with arm swing, or with but none of them had preoperative dyskinesia, or even 10% of that. This is the DTR, dopamine responsive dystonia. He's a businessman. And I'm very glad that my young neurologist diagnosed this case clinically. And then Professor Athar Javed, he confirmed. And now we're going to publish this very bad dyskinesias. The whole ward got horrified. Horrified. So we're going to get the biochemical marker. This is the post-operative. No dyskinesia. Okay, the gait might be imperfect, but no dyskinesia. That's great relief. Tayyib you have seen him yesterday. That was his preoperative. Bilateral tremors. He's a very intelligent man. I was very reluctant to operate on him because he was 73. But I did it. He was ambulant with a Zimmer frame only. At home. Very educated family. Just take few steps. You know, that was the state. This is post-operative. He's 73 minded and his speech volume is better, although it could be dysarthric component. He did not have any left-sided problems at that time. I have only done programming once. But you know, I gather he's got some dystonic symptom on left side. We can always switch to bipolar. It takes many months. It's very important. One setting is not enough. It takes many months. जैसे मैं अक्सर समझाता हूँ कि शादी के बाद जैसे हस्बैंड वाइफ की अंडरस्टैंडिंग जो होती है ना, उसको कुछ टाइम लगता है, साल लगता है. तो साल ही जो है ना वो DBS और मेडिसिन को आपस में समझने के लिए लगता है. So don't consider it miracle and a match made in heavens which would work from day one. You know, it takes a while. This is the team. This is my friend Nail, the proctor, who stopped coming to us because now we are doing everything ourselves. I've got a whole team. I've got 23 residents, PG, and 5 of them, the topic is the functional. I changed among GPI target, STN target, stimulation. They are all dedicated team, alhamdulillah. They are with me all the time. One is making movie, one is helping me the frame, one is calculations, one is like, you know, moral sport, you know. I'm very privileged to have such a decent number of trainees who are only working for functional neurosurgery. That was all the media coverage we had. In the post-op programming, medicine adjustment, rehabilitation, we have started movement disorder and we have incorporated a physiotherapist in that, and we think that they have a great role in the balance exercises, because these patients have a balance problem. So there's special sort of exercises they give which a normal physiotherapist would not, and you need a special equipment for physician programmer, gifted to me by Medtronic, cost $10,000 US otherwise. A new version is coming and I hope they will give it to me. Yusuf is sitting behind. Right. You know all these parameters. You know the beauty, you know what's beauty about DBS? You know, when you make a lesional surgery is one-off. Once you have done it, you can't change it. It has got 4 contact points. You know, no matter what precision you use and no matter which part of the world you belong to, there is bound to be some deviation from the actual target. And DBS through these contact points allows you to play with that. ये इसका ना निचोड़ है इसका DBS का. You can stimulate this and only this one, only this one, only this one, only this one, two of those, skip one, you know, all sort of combinations, and with the coverage around. So if you are, it is slightly imperfectly placed, you can cover it up, which you can't cover it up with lesional surgery. That's the main difference between DBS. And मैं मजे की बात बताऊं, जब हम lesional surgery करते हैं, तो we always stimulate first, and with 150 frequency, the tremor stops and rigidity gets better if it's GPI. And that's how Professor Benabed thought that why not to devise a machine which can continuously keep on stimulating it so that once you stop it, it gets reversible. So that was the lesional surgery, the stimulation was the basis of modern DBS. That's how it was discovered. Now these are monopolar, bipolar, stimulation parameters, the voltage, the other things, you know. Now, this is the usual stuff we have. We start with 60, 130. We have the 60 is the pulse width, 130, and usually our voltage is peri 3. We start with 2, 2.5, but rarely have to go above 3.5 because there are two reasons. One is it drains more, and up till now, among all these 16 paces, I have not done even a single bipolar. It means none of them had a capsular effects. I understand that if you have a capsular, you can do bipolar. I never had to use bipolar. All my patients are on monopolar. Most of them are 60. 3 or 4 are on 90. Almost, I think 14 of them are, 13 or 14 of them are on 130. Only some are on 3 or 4 are on 150 or 160. So this is they have a dramatic response on dyskinesia and motor fluctuations. Now this is the tremors baseline, you know, it goes down, rigidity goes down, reduction in medicines goes down as well. Complications, this is just last actually. There was not a single case of infection. We were unlucky to have one small hematoma that caused hemiplegia. But once I got hematoma, she was an elderly lady, I said, I'm not going to do next DBS till I improve my trajectory on surgery plan. And I collaborated with surgery plan team and those surgeons who use surgery plan. And till I got updated, there was some flaws in my trajectory. Because if you are near a vessel, you can cause hematoma. I was not getting 3D visualization. So, and there was no surgery plan trained sport in Pakistan. So unless I sorted that out, I did not do the next case. That case was an eye-opener for me, that why this bloody hell, why the hematoma is there. The cost, lowest 20,000 only. And thanks very much for your attention.
So thank you, Professor Jooma, for your kind introduction, and Professor Khalid. I'm fascinated, and I recall two episodes. One, a story by my father, which he tells every time. When he came back in 1964, he stayed 3 days with the senior Professor Jooma. And he said he tried to convince me, and he had almost made his decision to stay in Karachi with him. But then he realized that, you know, if I don't go back home, which was Punjab, then Punjab will always be underdeveloped. And if he had listened to Professor Jooma, probably all the credit Dr. Khalid has shown and all the cases and history probably would have gone to Karachi. Secondly, last year, about May, Khalid, May or June, Khalid was, you know, that's the great thing about him. He's been talking about it. He's been wanting to do it. He's talked to me so many times. And I believe in this Nike principle, just do it. You know, you have to do it, otherwise you will never do it. So he came and he met with me. I was visiting in, I think it was May last year, and he was planning. And we sat down, we discussed, I reviewed my cases, how things are done and all that. He had already been to Amsterdam. I offered him to come to me. I do about three to four cases a month. So in those weeks, he had already, when you're Sarkari Mulazim, you get time off at a certain time. So he wanted to come in July when I was coming here. So we went to Abu and we sat with him. His office is next doors. And I remember my father used to say, he passed away in December, but he used to say, don't compromise. So I said, Abu, maybe in Pakistan, maybe telemotomy is the best thing for these patients. Nobody can afford, and maybe you should. He said, no, you have to do the right thing. And I'm very happy that Khalid did it, and he's done 16 cases. So let me talk about briefly with my experience. And Professor Rasheed Jooma, I've been talking to him as an elder brother also all the time. I visited him. And let's see when that time comes when I'm physically back to Pakistan. He's been very encouraging. So this is a question I've been asked by patients as well as many meetings we go to. Can DBS surgery fix Parkinson's? And I leave the question to you guys. And my answer to that is no. But we can modify the motor symptoms of the disease. So there's no financial disclosure. It is a very intricate and team-based surgery. Like Dr. Khalid has already shown, I always give credit to the people I've learned from. In 2007, when I was getting done, I sat with Professor Haj, who was my chairman, and I asked him what he would do differently. He was in his late 60s then. He said, all neurosurgeons have egos. He said, you will never be able to clip an aneurysm better than I do. So that's what he said. But even though he always acknowledged that his trainees are very well trained, but he said functional is the future. So I took a job in Ohio, which paid for my fellowship. So I used to do Monday to Friday fellowship at Mayo Clinic. I did it for almost 5 months, and then took call on the weekend when I came back. So this is where I learned. So Kendall Lee, who's a good friend of mine, he is the busiest surgeon, DBS surgeon in the world right now. He does 4 to 5 cases a week, bilateral. And neurology, Matt Stead, good friend. This is like I always say, you have to have a collaborative approach. And then the Medtronic Neuromodulation team has been a big support all along. I'm looking forward to St. Jude's now, and we'll see how the competition plays, and maybe the cost can be. And then I've developed 2 teams, one in Ohio at Kettering Hospital, which was the first hospital I joined after training. And then my neurologist, Dr. Phil Hanna, Steve Bloomfield, Jacqueline Christini. Moving on, we won't go into the details. You've already seen the, what a DBS is. But neuromodulation indications. So essential tremor, Parkinson disease, dystonia, intractable epilepsy, Tourette's, depression. Depression is my biggest interest right now, by the way. And I have a couple of patients in US. So I get patients from Pakistan, in fact, who've come and gotten surgery in Karachi, Peshawar. I have patients, who've come there. But those are the patients who can afford. If you can get in 20 lakhs, why not do it in Pakistan? This is, I think, all the world should come over here to get surgery done. And I think this is where Khalid and we are probably going to collaborate. And I think there's a huge future in Pakistan. If India can do it, we can do it also. So established currently for Parkinson's, dystonia. GPI is the target for dystonia. Tremor via hypothalamus. The emerging treatment. So this is a talk I spoke at the World Stereotactic Society also in Korea about a year and a half ago. And I'm very fascinated with some of the work which is being done in Korea and Japan, like the epilepsy work, so anterior thalamic stimulation. Tourette Syndrome, we've done a few cases, OCD, depression, like I mentioned, chronic pain. Alzheimer's is such a wide area. Once we have the target, which a lot of experimental work has been done, then TBI, traumatic disorder, brain, after car accidents and all that. Japanese literature is showing promise on some of the cases. obesity, we believe hypothalamic stimulation is the future. It's just a matter of time. Once you can see it, and we'll show you how you can see on MRI, and then chronic pain. This is, let's talk about DBS and MCS. I think this is a wide variety. There's spinal cord stimulation also as part of neuromodulation, which we've been doing for at least 15 years I can think of since I started training. But I think that comes in more in spine domain, which we do all the time. So early DBS is superior to medical management. Recent literature has proved that 5 to 10 years is the golden, in our opinion. And our neurologist over here, who are visiting, when Dr. Javad Bajwa had approached me about this meeting, I thought this would be a great thing to be doing, and I would like to thank Professor Arslan and the team to get this organized, because I think this is the first milestone. And yesterday, their first movement disorder society was established with Dr. Nadir as the first president. I think we are moving ahead in the right direction. Collaborative, building bridges. This is what combined neurosciences should be. So ideal candidate, idiopathic PD. There's no real age cutoff. Khalid has done 74. I've done an 89-year-old gentleman also. It all depends on the medical condition of the patient. If somebody has made it to 80, we believe that they don't have diabetes or high blood pressure coronary. There's sky's the limit. There are a lot of patients who are living much longer. But that's the Western world, so maybe it's a different locally over here. Motor fluctuations, excellent levodopa response is a requirement. Patients should not have freezing, no postural instability, no dementia. Mr. President, since I'm combining two talks, so I'll be getting a little bit extra time then. Okay, so timing is extremely important. So if the surgery is performed too early in the course of disease, when the patients are able to manage with medications alone, I think that's too mature. We are just putting them through extra risk of surgery. Professor Khalid mentioned, there's badness that can happen. We've been very blessed. I've done 473 cases by now. These are cases, not so you can almost double it. We've had 4 infections now, so that's about 1.3% infection rate. The more you do, I saw more infection in Mayo Clinic because when you do 4 a week, of course you'll have more infection. But bleeding, and we'll talk about a little bit of complications as we go. And 5 to 10 years of PD diagnosis, I think this is an ideal. Let's show you a couple of videos. This may not have the audio. This is a patient we had done, in fact, when I was at Mayo at that time. So a typical PD patient, shuffling gait. You can see the very high frequency tremor on the left upper extremity. 8 months after implant. I tend to agree with Dr. Khalid. I really don't consider it as a marriage, but it takes about a year to really 6 months to a year is really when you start seeing the effects. He's out. This is typical Minnesota out dancing. I think it changes the lifestyle of the patient. Now I can think of many patients. So this is where I would like to give our experience, who are off medications. So I think the targeting is extremely important. We'll talk about details on that. But the patient also, how the neurologist, how they manage the medications and how they do the, programming. So that's why I always say that, we are neurosurgeons, we should do the surgical aspect of that and get our neurology friends on board with this. Because I don't think I'll be able to program it better than Danish or Javad, because this is what they have expertise and spend 2 to 3 years doing that. I will never be able to do that, and I think the neurosurgeon probably should not be doing that also. And at the same time, so Comprehensive Neuromodulation Center. This is what a DBS center should be having. Professor Khalid has already developed one. Preoperative evaluation, operative procedure, but that's not where the DBS center ends. That's where it starts, in my opinion. So what happens after the surgery is the real management of the disease. Post-op programming and medical management, medication management. Now, I also used to believe in unipolar programming, but my neurologist, just came back a few months ago, and they have started programming everybody with bipolar now. And they are showing, so that's why when we saw that patient yesterday, I said, this R3 and this may be overcome by trying different parameters. Battery replacements, all of that. So when you do more, you'll start seeing more and more So if the generator is not lasting you more than 2 years for a PD patient, Parkinson patient, then there's a problem. So that means you're using too much high voltage. So placement could be adjusted a little better. But if a dystonia patient requires that, that's because that requires much more higher voltage to do that. So preoperative evaluation, I won't go into details a lot. Consultation with speech, tremor, electrophase, neuropsych, psychiatric evaluation is done by, if somebody has dementia, I think I'm the last person to see that patient. After they've all been all of that, our DBS committee approves them, and we meet weekly or bi-weekly basis. And this is our committee. So it's a weekly, this is what I inherited from Mayo Clinic. So I saw that, and I've reproduced it this is the second time I've done it. And then the consensus has to be reached whether to offer surgery and which structure to target. I leave the structure target open till the morning of the surgery because I want my neurologist to be happy, because I don't want to hear a patient, he's having this. So we will stimulate to up to 4 volts at least till they're happy, because then, at least my job is done, and we can basically move ahead with a good placement. And neuropsychology testing is a mandatory. Why we staged, when I started in 2007, Mayo was doing in single stage, so I started doing them I did them for about 2 years. And then the hospital came up to us that, we're losing money. So this is the real reason we're staging it, because the first stage is, they don't tell this. Medtronic will never tell you, but that's the real reason, because that's 2 surgeries. First is awake surgery, second is under general anesthesia. Then it becomes really, really positive, and they make much more money. So this is the real reason. So history, Khalid has already touched briefly. 1950s, stimulation of septal region. Started with schizophrenia, in fact. And the psychiatrists were, in fact, the people who took the lead on. The 1960s, stimulation for pain. I will be showing some cases of pain also, motor cortex stimulation. And then caudate and thalamic, 1960s, thalamotomy was basically taking over the pallidotomies. 1970s, levodopa was introduced. So interest in surgical treatment basically just went away in 1970s. And you will see in one of the slides, which is from Pakistan, that the number of cases also went down. So, but in 80s, there was renewed interest, because there were more and more side effects. A lot of patients were not responding well to levodopa for long-term use. And then, smaller ablations, electrophase targeting, high-frequency stimulation. So all of this was being developed. And Benabid in French, of course, it started from France. Just like the endovascular coiling also came from GDC was from that part. So later he reported STN stimulation for PD. 97 is when FDA approved the thalamic DBS for thalamic. And then 2002, FDA approved STN and GPI. And subsequently, 2003 is when the GPI DBS for dystonia was approved. So 1964, this is the best part of my talk. I show this. I'm very proud of this also. But this is 1964. This is the frame this is my father's frame. This is what he used to use in 64. And in fact, it started from Multan. He started doing this in Multan, and then they moved the entire center to Lahore, which is also a story. But this is what we use now. So this is we moved to the Lexel G. This is the same frame I use for gamma knife. I do a lot of gamma knife also and I think the future is if you have to do lesioning, maybe, if you look at some of the French in Marseille, there's a lot of interest in radiosurgery for functional. Now, in US, in the Western world, there are a lot of restrictions on us, but in developing world, you can do a lot of other stuff also if you have the tools. That's him doing in 1960s. And it is probably very close to the theater Dr. Khalid is using now. This is probably the old theater. And that's him, that's not me. Those are these pictures. And this is a very interesting slide I show, stereotactic history in Parkinson's. So from December 64 to 88, they had done 1144 cases. This is higher than any country you can think of at a time when India and all these countries didn't even do these things. And you can see that in how the number of cases went down in 70s. This is when the levodopa came in, right? But I asked him why the cases kept on going down. He said because I was getting busier and busier doing other stuff, and there was so much. Everybody was coming to Lahore now. So now in 2015, this is the frame we use. We do a G frame. Functional gamma knife, like I mentioned, CT and MRI fuse. So I used to do MRI-based pre and post, but now I get an MRI as an outpatient, which is much more convenient for the patient. You have to put a frame on, and then you got to put them through the MRI. It's a little bit more tedious. I just get a CT and fuse them. On the Stim Pilot, this is what we used before. And then Kinetra, which is the sole. I use a single generator. This is what we've done initially. This is the preoperative planning MRI. This is the intraoperating. So at Mayo, we were fortunate to have an intraoperative MRI. So right after the procedure, we were doing it in the intra suite. So we're doing MRI because Kendall Lee used to reinforce that you have to get an imaging right away because this is how you will learn. And I think this is very true because if you don't see, this is like putting pedicle screws in when we do spine surgery. We used to put screw, multi-level fusion and then get a CT because that's the only time you'll be able to critique yourself and not blame on somebody else that, this happened afterwards or something moved and all that. If you get this imaging, which I still do to this point, that you will not be having issues. So this is the postero-inferior part of the, if you see this right here, this is not a good picture, but I'll show you as we move ahead. And then this is a lead placement, and then I'll show you post intraop stimulation. We stimulate at least up to 4 volts in an awake patient and with the externalized leads. And the purpose is to see the clinical benefit, but more to see the side effects. You would rather see them there than to see them at some other forum. And then possible dysarthria and oculomotor problems are real if you don't stimulate to, you can be fooled even up to 3 volts. 4 I think is the magic number. You don't want to go even higher than that. But so this is on the left STN. You can see the right, pre, post. Pre, post. So we make them right, we make them, I'm sure Danish and you guys do the same in surgery over there. And post-op CT. So since MRI stuff, so I get a 1 millimeter cut CT now. First, to look for hemorrhage, because you can have a subtle hemorrhage which you didn't think you had caused, but I had unfortunately taken care of a surgeon's case, which is about a couple of miles from my hospital. And he was out of town, so I took care of it. But nobody expected that there'll be a brain hemorrhage when the patient was in the rehab. So you can see, so we want to line up the electrode with the track in the post-op MRI. So you can see the track over here, and you can see the lead. So this is how accurate you can see. This was on the MRI. So this is very fortunately, we did a very interesting case. I want to show you this because this has taken national media, which we were recorded live a couple of months ago. This is a 32-year gentleman. This was on the national PBS news the same evening. This is Jackie, who's my nurse. She does all the programming, by the way. She and the neurologist.
In his mid-30s. It's one of the worst cases doctors at JFK Medical Center in Edison have ever
This is our operating room.
But today, he's undergoing deep brain stimulation surgery, a procedure used to turn those tremors off.
So this is the lead that will connect to the microelectrode.
Dr. Asif Bashir and his team are inserting a thin, insulated wire called a lead. It's connected to another wire that monitors the activity of nerve cells and
The
targets
lead point,
signals
we
that
still use the
cause
Medtronic one. I prefer that,
symptoms.
the portable
The
one.
picture, John is awake, but mildly
Look at the
sedated
tremor,
for the
very violent
entire
tremor.
procedure.
So we are basically listening to the brain. As you pass from the thalamus into the deeper part of the brain, which is the subthalamus, the activity goes up, and Dr. Hannah and her team is able to track the waves over there, as well as we can listen to the activity.
They use an MRI and audio cues to locate the exact target
The
of
planning.
brain where the nerve signals generate the symptoms. Listen closely. That rain on a tin roof sound is actually John's brain responding to the electrode.
And we can hear the brain activity go up, telling us we're getting close to the target.
They'll send electrical impulses from a neurostimulator through the wire into the brain and block the signals causing the tremors.
It's very similar to a cardiac pacemaker, and it goes in the same area of the chest as a cardiac pacemaker. It's just about the same size.
And right now, doctors are fine-tuning and trying to find the appropriate balance between the highest voltage needed to turn the tremor off without causing a side effect.
That target is not.
So we had bilateral STN, excellent placement, no side effect, but the tremor was still not responding. So,
The brain at a different site that will.
so we decided to do a VIM and STN together on the left side, which took care of the problem. It's a very delicate way to do it, to extend the burr hole posteriorly.
Turn it on again and take over the tremor. There we go. The prognosis will be very good once you have the tremor under control. Then basically, as long as you keep on changing the generator every 4 or 5 years, all the motor symptoms are controlled for life.
It means it's not the end of the road for the young father of two, it's the start of a brand new one. In Edison, I'm Brianna Bonozzi, NJTV News.
So there are two things, other than the publicity we got with it, but there was a lot of learning from this case, because this case was referred to us from Columbia. This is a patient from Phoenix, Arizona, was on Parkinson meds for almost 6-7 years before that, but nobody realized that he was on this medication called Mirapex. So he was a very high-profile business person in Phoenix, and then he became a compulsive gambler. And then, hypersexuality, hyper-gambling and all that, he lost everything till he had to move to his parents in New York. And when he went to Columbia, the first thing they did was they stopped his Mirapex, and all the symptoms were reversed after a few weeks, but the hyper symptoms. And then he was considered for surgery, and we were able to take care of this. They decided to come to us because Jackie basically programs all the patients in New York and vicinity. So I can take you through these videos. There are many videos I can show you. This is another patient we did. We see a lot of Hispanic population, and like I said yesterday, I think I've done about 6 Patels also. So this is very common in that population. So this is our office. This is after the surgery, and this is turned off. He's unable to drink water, just like any PD patient. Significant tremor. I've had 2 patients we have had to revise. We did STN about 5 years ago, and there was a tremor reemergence. So what we did was we either added a VIM to that or removed the STN and added a VIM. So if they have milder rigidity and all that, so this is post-op. The ADLs, the activities of daily living. So before surgery, you can see about 30s, and then with surgery, the on time. So basically the on time is, DBS is taking over the on time. And it's very similar to with Medicare, but the goal is, our team's goal is to get them off, wean them off as much medications as possible, and I think it's happening. So intraoperative exercise recordings from STN. I'm going to move on. I have a lot of slides. High frequency stimulation. We don't know the mechanism, but results in increased action potential firing in the dopaminergic substantia nigra neurons. This has been shown in the lab. So how do we measure the dopamine? So I'm involved still with my colleagues at Mayo Clinic, and we are working on this dopamine amperometry, which has been recently published also. We started off with rats and awake monkeys, the work which was being done there, to measure the dopamine. So have a neurophysiological, if you can measure that and see where the dopamine levels are and the combine, do the fusion. So neurochemistry combined with the fusion imaging, neuroanatomy, the sky is the limit. And now going up to 3 Tesla, hopefully we'll have in Pakistan, but 7 Tesla, I'll show you some of the pictures. If you can see it, I don't know why, there's no limit to it where you can go. So this is a standard 1.5 Tesla on the left side, and you can see look at the brainstem imaging on the right side, the brainstem. You can see the fibers, you can see the you can get pretty much try to target any part of the brain on such a high, again 7 Tesla on the right side, left also, different images. You can directly basically see the STN. So as we are moving with the imaging, so effectively these are certain slides I will go through briefly. This is an effectively placed bilateral STN, and you can see that the dorsolateral aspect of the STN is the target, and it gives us reduction on the PD symptoms and all that. Let's move on. So what happens if you have medially observed? I'll just briefly, so as you're going through that, if you are going a little bit medial, you're going to hit the cranial nerve third, which is coming right over here, and you're going to have diplopia, deviation of the eye. So that's why stimulation is so much important intraoperatively to high frequency. And if you go a little bit posteromedial, you're going to hit the red nucleus. Theoretically, if you hit that, you'll have sweating, nausea, vomiting, paresthesias, and all these things which can happen. And if you hit the limbic STN, which is more ventromedial, you'll have possibly personality changes with the onset of depression also. If it's STN is a very small target, you want to have at least 6 millimeter covered with your DBS electrode with that. So if it's a laterally placed, this is the STN, this is the SNR. If you are hitting the lateral, you can have a sort of a bulbar, corticobulbar, and you can have the contractures, facial contractures, as well as facial pulling. Dysarthria, in fact, comes if you are a little bit more lateral. So if you hit the frontal eye fields, then you're going to have a contralateral eye deviation. Let's see what happens when you go anterior. If you are a little bit more anterior, which is right here, this is so you can have, again, corticospinal, which is more anterolateral, as well as contractures of the body. And if you are more anteromedial, you're going to hit the hypothalamus. So that will give you autonomic symptoms and sweating and flushing and all that. If the target, theoretically, if you go more posterior, and these are you'll see paresthesia. So posterior, P for, this is how I remember, you'll get more paresthesias and tingling. And this is what, if you have that, you want to move the lead about 1 millimeter anterior to that. These slides, I used from Medtronic, they have very nice atlas, which we have used for, and then if you're superior, of course, you'll have possible dyskinesias and possible reemergence of the tremor, and you can have muscle contractions if you are hitting the internal capsule supralaterally. And inferiorly, if you go, you're going to hit the SNR, which can possible mood changes and depression and all those things. So this is, every millimeter counts in this when you're doing this DBS surgery. Every millimeter counts. So you have to be, that's why direct targeting has not taken, I've done a few cases with direct MRI targeting also. It takes longer. The problem with that is the patient is not awake. And you can directly target the STN or the GPI, but when the patient wakes up, sometimes they have these, because that's why intraoperative stimulation is still the gold standard, if they're awake, and you can curb those side effects right there. GPI, globus pallidus interna, for, this is basically, I never expected this, but she took this picture before surgery. I never knew that this would, because when you do dystonia, you don't expect, this is a patient with a torticollis and a crooked, the neck is basically totally angled towards the left side. This is on, so 8th of July, 2009. And I had to ask the next day picture because when I heard next morning, this is hers. So this was just on a very, very small amount of stimulation. So they are outliers. They're patients who need just a day of stimulation, and you can have a neck straightened out. But that's not the routine. GPI stimulation requires more of. So effectively placed bilateral GPI, that's for dystonia. We talked about that briefly. I'm going to fly through this because there are a lot of slide pictures like this. And if you are a little bit more medial, you can have muscle contractions. If you are going more lateral, as you see with the red, with the star in there, you can hit the putamen. You won't have any significant effect from the, and maybe a possible improvement in the PD symptoms. If you are more anterior, no real effect, possible improvement again in the PD. And if you are in the GPI but you're more posterior, so you can have the posterior limb of the internal capsule. So that'll give you, can give you hemiparesis as well as muscle contractions. So, and then again, if you're GP superior, you'll end up in the GP externa, which will again give you possible improvement in the PD symptoms, but not really in the dystonia. And inferiorly, again, inferiorly is the most worrisome in my opinion when you do a GP. That's why when we do this, because the you can see the optic tract is there. So you can have these flashing lights and all that, and contralateral sometimes issues with that. So we have done then more under general anesthesia now, because when we plan, we are looking at the optic tract. So that's why I think it's better to do it. So VIM, briefly again, the effectively placed in the inferior part of the VIM, infra-posterior part of that, gives an excellent tremor. VIM is the target. If you have a PD patient who has mainly tremor, we are likely switching more and more, especially patient is younger, to if they don't have much of rigidity, or you're better off just doing a VIM for them. And you can see medially observed again dysarthria if you're a little too medial because of the to the medial thalamic nucleus. And if you go lateral, you're going to hit the posterior limb of the internal capsule again, and that can also give you muscle contractions, facial pulling. Moving on to anterior. So all of these, we know that if you use a millimeter targeting, or you move your lead, you can have various side effects which may be unwanted. And then if you go more posterior again, VIM, you'll have paresthesias. So fine line as we do. Superiorly, you won't have a very good tremor control if you come out of that. And if you are more lateral and dorsal in the, you're going to have again contractures of the and dysarthria. Again, inferiorly, complications. So let's talk about that. I briefly mentioned the literature basically reports about 5% infection rate, 5 to 7% in fact. So we've been very blessed. The more precautions you take, the best it is. I personally feel for the patient, single stage is the best. If I was doing these in Pakistan, I would just do stage 1 and 2 together because there's no issue with the reimbursement and all that. Hemorrhage, we've never had one. Air embolism, I've seen one at Mayo Clinic while I was a fellow, and technically I didn't know what to do, and anesthesia and all of these, because this is an open, basically craniotomy, your hole is open, so you want to bring them down in general neurosurgery. And at that time, we basically turned him onto the side, put wet gauze on that, and just covered the hole, but the patient did fine. And then, so you want to have a Doppler, it may be an overkill to have a Doppler placed for every patient. Seizures have been reported, tunneling mishaps have been reported. Sometimes you're tunneling, it can come out of the very thick-skinned patients. We've never had a seizure. I think that the key is in planning. So I spend about an hour planning because I look at the blood vessels, looking in through the sulci while we're planning. And giving double contrast is also helpful sometimes because then you can see the vessels a little bit more. Death can happen. If somebody has developed a brain hemorrhage, they are reported deaths from DBS. We've been very blessed, but if you plan it accordingly, I really don't think, other than infection, you should be, the more cases you will do, Khalid has done 16, I think his numbers are, once, you know, you do more and more cases, you know, and it's so heartbreaking when you have your first infection. I, in fact, had it about 9 months ago, the first time ever. And since then, we've had 3 infections all of a sudden, and we found out what the problem was. It was in the sterility of the frame, in fact. So we changed everything. So we've had 3 and 1 generator, so 4 infections altogether. This is another patient from our neighboring hospital. This can happen. The patient had significant hemiparesis. In fact, was in our rehab. We have an excellent rehab at JFK, so they get surgery. And this was picked up in the rehab done by another surgeon. So they, in fact, had called me to consider doing the stage 2 because the patient wanted to get it done with us. I said, let's get a CT, and this is what we found out because it was a little clumsy on the right side. So Tourette Syndrome. Tourette's, we've done a few cases. In fact, more at Mayo Clinic. In fact, we have an excellent paper coming out of Tourette's with me and Dr. Lee in American Stereotactic Journal soon. Centromedial thalamus of the thalamic stimulation. This is an excellent case, which a young patient, I think he was 19 or 20 when we did him. So significant vocal motor tics. Somehow we don't see that much dystonia. I think here, Khalid and you guys are seeing probably more dystonia. I was asking them in Karachi also. I think the patient population is referral based also. He can't even walk properly, and initially the neurologist thought he's mimicking this. So we made a video of him. He didn't know that he was being videotaped at that time. This is after the first adjustment. You can see the visible difference. You can hold a cup of coffee. So it's a very anterior target if you do central, so you have to go closer to the forehead. Okay, so mechanisms of DBS. We don't know how it works. Nobody knows how it works. A lot of stuff we do for neurosurgery, there's no class 1 data to prove that. But you know, things are moving ahead. We have potential mechanisms, and that's why we have to collaborate with our. I call the neurologists, you know, the brainy neuro people, because you know, I think as surgeons, you know, we are technically there, but I think we have a lot to learn from our neurology friends. So, potential mechanism: DBS activates the astrocytes. Increases the intracellular calcium, vesicular fusion, glutamate, which is an excitatory neurotransmitter, and then there's modulation of the neural network. This is the potential. A lot of thalamic relay cells, you know, this is work in the lab. I don't know if you have so thalamic, this is the intraoperative thalamic relay cells. So at Mayo, we used to do a lot of, you know, spend almost hours because the neurology people a lot of, but right now, since we do a very high volume, so these are the thalamic relays. So this is how it sounds. And so it takes, surgical part takes about an hour on one side, about an hour on the other, about 2 hours. So from 10 to noon, the surgery is done for at least the stage 1, but about an hour for planning before that also. And so let's keep on moving ahead. A lot of interesting thalamic slices, spindle waves, glutamate mirroring. You know, this is imperometry is where we are heading. I think a smart DBS system, which I'm actively involved with the Mayo guys, which is not too far, I think. I'll show you what it may look like. High frequency stimulations. Conclusion, DBS glutamate release is basically in part non-neuronal origin. DBS glutamate release, again, astrocytic cultures. Let's quickly move on. Intraoperative fluorescent microscopy of the astrocytic pictures, which are taken from lab. And so we know that astrocytic glutamate release is mediated by rise in intracellular calcium. This is well documented now in the lab now on rat models and This is the potential mechanism as we're moving ahead. So WINKS is something, it already is, this first part was in the neurosurgery focus, which was developed, and we are working very actively. So it's basically real-time neurochemical detection for accurate DBS placement. So if you know as your neurotransmitters are going up and you're targeting anatomically also, I think that's where the future DBS system is heading towards. And it would require the automatic modulation of the stimulation parameters. This is what, so it is within 5 years, I would expect that a similar system here, or so this connection from here to here is going to be obsolete. And you'll have a smart sensor right here, which is the wireless, sensor. And you basically would be able to do the sensing of the transmitters as well as have a infrared control over there to be able to do a plan on the stimulation. So emerging indications for DBS. So I talked briefly about epilepsy, anterior thalamic. I've given a couple of grand rounds on epilepsy. I have not done a case yet. I'm looking forward to doing this. If Khalid can line up a couple of epilepsy, maybe we can do it without FDA approval. The Tourette's, I've showed you cases, OCD, depression. Unfortunately, the two studies, Nasir has worked with Lozano. He was involved with the two major studies which have not shown very promising results. So as we are moving ahead, I think the target is the issue, and you have to work very closely with the psychiatrist. So we see future is neurology, psychiatry, and neurosurgery combined. Just like you guys are having your combined neuroscience grand rounds, I think that's where the future is heading towards. Chronic pain. I'll touch briefly on the chronic pain because I think that's where when I come to Pakistan, I see a lot of patients, post-stroke patients. So briefly, motor cortex stimulation. So what it is, in our opinion, this is a last chance therapy after all the previous treatments have failed. And for chronic, for post-stroke, for deafferent trigeminal neuralgia, atypical sort of trigeminals who have not responded to other treatments. Mechanism, again, is unknown, but more likely because of the stimulation of the damaged afferents, which likely establish the inhibition of the nociceptive pain fibers. It's an off-label procedure again, not approved yet. In carefully selected patient, we are seeing, I would say more than 50%, but you tell the patient, maybe up to 50% chance that your pain will improve. But we see more than that in the carefully selected, how it is done. So, so we are basically, there was an initial interest, if you look at historically also, on the somatosensory stimulation, but then it switched to the motor targeting for the motor cortex. So this is the motor cortex, this is the homunculus, how we target it. This is done without the frame, frameless navigation. I use stealth. You can use Stryker. There's monitored anesthesia. You can use general also. It's a small linear incision. Another thing I saw in Dr. Khalid's, is the incision. And maybe Khalid and I will discuss this. There's another, so our incisions are about an inch long and linear incision. So not a big, like a U. Initially, this is how the surgeons used to do, and this is when we used to do at Syracuse also when I was in training. But now we just do small, straight, linear incision, about an inch on either side, not bigger than that. And we've had excellent results with that. So we do a similar linear incision. I think, it's a minimally invasive world. Patients are asking for it. Even in Pakistan, patients want minimally invasive surgery, brain, spine, and why shouldn't we do it? It is just a different way of doing it. Once you've done it open, you just have to change your perspective and start doing spine. Dr. Jooma mentioned, I probably do about 70% spine. All percutaneous, but anything that hits the road, I think we should be able to take care of. So 4x4 electrode is placed, cortical homunculus is targeted, and then a small craniotomy, neurophys team again is there. 2 electrode arrays are placed, and this is the lead up there, intraoperative. This is how it looks, just like a DBS. It's the same generator. You use a Soletra for this instead of a now it's the SC instead of the PC, and this is intraoperative picture, small craniotomy. The next day they go home. So basically, this is where we are standing now. I think as the future is moving ahead, the lower parts of this slide is where we will be having more interest in. I think depression is the next frontier. Alzheimer's, there's a lot of interest in Alzheimer's. If you look at some of the work out of Johns Hopkins, some of the Japanese people are doing very good work. So I think this is, and working closely as a team with our neurology, psychiatry team, I think this is where we should be able to take it to the next frontier. And I think I'll be available for questions.
Asif, the follow-up talk is on DBS. Do you want to just go through that?
So I did the motor cortex and all that together. So if you look at that, we did the...
Sorry, your talk.
This was the combined. So it was about 20 minutes, and 20 minutes I combined with the other one also, yes.
I get it.
Yeah. So that's why, I had that as well as I added spinal cord stimulators and all that, but I thought that's more of a spine domain. So this is how we take the spinal cord stem. So I think we'll be available.
I definitely myself have a couple of questions, but maybe let's get Jawad as well, and then we can get the three speakers up here and spend some time.
Definitely.
Yeah. Jawad? I'll start. Good. So well done. Thank you very much.
Thank you.
We would also like to thank Hilton Pharma, OBS Pakistan Private Limited, OnTech Corporation, and Barrett Hodgson Pakistan Private Limited for the sponsors. Now I would like to request Dr. Nadir Ali Saeed, who is a consultant neurologist and heads the movement disorder section of PSN, to please come over on the stage to present the certificates and shields to the organizers. Thank you. First of all, Mr. Tanveer Ahmed Malik, who is the event manager. Mr. Nisar Ahmed. Ms. Rihana Khan. Ms. Rihana is the CME event organizer. Mr. Muhammad Adil, who is the organizer, CME. Yeah, there are certificates for Mr. Azhar Wasim, Mr. Waqas Ghafoor, Mr. Usman Ali, Mr. Shoaib Ahmed Khan, Mr. Zahoor Ahmed. All right, and there is a organizer shield for Dr. Ahmed Shah.
And last but not the least, Dr. Nabil. He's been in it from the beginning with all the computer work and the organization.
I would like to request Dr. Nadir Ali Saeed for the vote of thanks.
Thank you. I'm not going to keep you all here very late, but I think the first time type of meeting is held is very special, and I think we have some junior people, and I'm hoping in 20 years you will go to another meeting and say, you know, we went once, there were few people, but we were all very excited about it, and we decided to do something. And I think what we hope to do is give the young PGs and the young consultants an opportunity to take movement disorders forward so that Pakistan also is a center of excellence like any other place. It means developing human capacity amongst physicians, teaching patients, counseling, family, giving individual doctors, young doctors, opportunities to learn from people abroad, etc. Other than that, I would need to appreciate the vision of Dr. Bajwa, who really was the driving force, who envisioned this, and Dr. Arsalan and his team. And it is remarkable. I think Dr. Arsalan is amongst the champions of neurology in Pakistan, and the field of neurology owes a lot to people like him. I would also like to thank all the speakers and the audience who decided to stay till the end, and really the questions were really great, and I think this is really a good sign. We mentioned the pharmaceuticals. We also need to thank the gold sponsors, which was Novartis, the GSK, the silver sponsors, which was Novartis, then there was OBS and Hilton, and Medtronic, who's represented by Ontec. Very good. So I think their sponsorship and this teamwork is also very important. Okay, I'll end right here. Thank you very much. Thank you.